Okay, so hello and welcome to the Playing Field and CT webinar. My name is Seidel. I'm the Customer Success Specialist at Collective Minds. As always, all of you who have joined tonight should have an account on Collective Minds, meaning that you can watch these cases before and after the webinar. The webinar is also recorded and uploaded to a YouTube channel, so if you would like to review the cases again, feel free to do so. So go into YouTube and look at the case on Collective Minds. We have a couple of cases that's donated tonight. So I would like to say a big thank you to Roar Pedersen, who is a consultant radiologist at Unilabs in Norway. And then I would like to say a big thank you to Martin Michel, who's a radiographer in the UK. So big thank you. Imran is going to look at the cases. And for those who don't know, if you want Imran to look at your case, all you have to do essentially is upload your case into the global community and tag Doc Lasker, like Martin have done right here. Closer to the end of the webinar, I'm going to send a evaluation form. So take some time and fill that out. It really helps us provide better quality webinars for you. And I would like to say a big thank you for all the nice comments. It's actually almost all of you who are joining actually submit an answer. So thank you so much for that. And I think that is it. So let's see if Dr. Lasker is here.
Hello, everyone. I hope everyone is well. Thank you so much for joining the webinar today. I'm just going to share my screen. I hope everyone is enjoying. I don't know, actually, everyone's from so many places. So the weather's here is pretty good, so which is quite nice, but a little bit hot. Right, so what I'm going to do, I'm just going to try and make sure that we do get a bit of interaction when we do these. It's always nice to know what people are saying. If anyone's got any questions, I'm happy to go back through things if people need to. We try and keep it as informal as possible, right? So we just want to make sure that everyone, just has a bit of fun and hopefully learn a few things as we go through a few cases. So hopefully the link is now there. I think Sadi has just shared it. So that's going to be our 14th webinar today. And hopefully you can see my screen. So Sadi, you can confirm that you can see the screen and we'll carry on. We're going through the cases that we have. So, okay, right. So what we're going to do, we're going to have a look at this X-ray. And what I like to do, if possible, is for you guys to have a look yourselves and also write what you think is going on. Some of them may not be abnormal, or some of them may be a bit difficult, just depending on what level you're at. But I try and pitch things for all breadths, like whether you've never seen an X-ray before or whether you've seen loads of X-rays. I try and make sure there's some hard cases and some easy cases as well, just so that everyone has something to come away from. So let's have a look at this particular X-ray. And we just have to try and think about, okay, what are the very common areas that people have injuries? So I'm going to take out my little pen. And this is quite good, actually. So those that don't know, this is the Collective Minds radiology platform, and it's really fantastic. And I've recently realized that when you've got an iPad, you can press B for pen, and you can literally just draw live. And then, you can actually make your teaching sessions a lot more interactive and just feel like you're really there with someone. So one of the main things that you want to do whenever you're looking at any of these sort of X-rays is kind of, first of all, the main key areas I would say is to try and look at the 4th and 5th metacarpals. Okay, these are very important areas to look. The reason is because when people punch, they normally end up getting a translation of forces incorrectly through the phalanx, the metacarpal, and you end up getting fractures around the neck, or the fractures around the bases, or even fractures through to the actual bases, through to the articular surfaces. Very common, and that's actually the first place that I look whenever I'm looking for any sort of injury whatsoever. So on this hand X-ray, I haven't seen anything. So the next thing you'd want to do is make sure that you've had a good look at that scaphoid over there. So what we'll do, we'll just zoom in a bit first and just have a good look. So I always zoom. I really do make use of any sort of software that I have, just to give myself a bit of an advantage when I'm looking at these things, right? So first off here, you can see that this is the scaphoid. I'm just drawing it around like so. It looks very uniform. It doesn't look particularly sclerotic and doesn't look like there's any avascular necrosis. Avascular necrosis, where you get sort of a slow breakdown of the bones, and that can happen because of a lack of blood supply, fracture that hasn't quite healed. It can just be an ongoing process that can happen. But this is one of the places that you can have avascular necrosis secondary to injury, and it's all to do with the blood supply. If you get a fracture, you do get less blood supply going into the scaphoid, and that can end up becoming some avascular necrosis, right? The other place you can get avascular necrosis is the lunate. So that's the lunate over here. And that's another place you can get avascular necrosis. And it can be pretty much spontaneous and is known as Kienbock's disease. So that's something else to be aware of. But I haven't seen any fractures here. Obviously, let me know if you see a fracture. That'd be very interesting to see whether someone's got one. But the next thing you want to do is make sure that you've had a look at these metacarpal heads, make sure there's no fractures there. And I genuinely draw around every single one. So I literally just get my pen out or the mouse, and I draw around every single one just to make sure, even if it's just with my eyes, to make sure that, yeah, it looks completely smooth. There's no periosteal reaction. There's nothing that's telling me that this person's got a fracture within those regions, right? So one of the things here is that we don't have two views. Ideally, you want to have two views whenever you're doing any sort of x-rays, but I've only given one view so that we can try and have a look at some of the other problematic areas that someone can have a fracture. Now, the other place I've noticed that people can have fractures and can get missed is the hook of hamate. Now, the hook of hamate is this area over here, and it kind of pokes outwards, and it just seems to be an area where people can actually have injury. And the next place is going to be the triquetrum. Now, the triquetrum is very, very important to have a look at. Let's zoom in and zoom in and zoom in. And hopefully people can see that, yeah, you know what, when you zoom in there, that doesn't look quite right. Can people see that? Zoom in, zoom in, zoom in. And what I'll do, I'll draw around as well. So can you see there's like a radiolucent line just going this way, this way, this way, this way, like so. Can you see that? And you can see that's the triquetrum going over here. The pisiform is going to be sitting over here. But there's definitely this sort of radiolucent line. How do I know it's a fracture? Well, a vascular territory or a vascular linear area would have increased sclerosis as you go up to the radiolucency. So if you look at this area over here, there is a linear area over there, but it kind of gets a bit more dense as you go along, closer to it. But this one is not. It just shows kind of complete radiolucency along there, meaning that this is a triquetral fracture. It's a little bit more difficult, I thought. I don't think it's the easiest one to pick up, but if you kind of use that framework of, I'm going to look at the base of the fifth, base of the fourth, heads of the fourth, heads of the fifth, look at the scaphoid, and then go for the triquetrum, then usually you'd find a fracture. And then if you don't find a thing, you're really going to have to do the long haul and go through every single bone the way I did earlier, where I was kind of going through, drawing around. Okay, so this one, let's have a look. So no questions so far. Let's have a look at this one. So one of the things I do whenever we're looking at these x-rays is go for the parts that the x-ray wasn't really meant for, if that makes any sense. So this is clearly an x-ray of a forearm and a wrist. But what I'm going to end up doing is having a look at that kind of elbow, make sure there's nothing abnormal, because there's usually those kind of edge of film areas that end up having a miss. And so what you do here, just make sure that you can draw all the way around like so, all the way around like so. Can you see this radiolucent line? It looks very sclerotic or very, very dense as you get close to the edges. So therefore, this must be a growth plate, and therefore this must be completely normal. And then you've got your radial head, and that can be a little bit difficult to try and draw out, but what you need to do is go all the way around like so, like so, like so. And can you see how you kind of almost draw on where it is, and you kind of have a bit of an idea about what the normal anatomy should look like? So that's going to be the ulnar over there, because without it, it just looks like a complete amalgamation of everything. But actually, this looks okay. So, oh yeah, we do have a poll on this one as well. So if those of you that do get to see the fracture, do tell us what you think it is, okay? And the options are rodeo, horse, buck, or buckle. So I'm going to move that to the other screen. And so a few people have got it, but no one's actually mentioned anything on the general chat. So what we'll do is, again, you just really want to make sure you draw all the way along the edges like so, all the way along the edges like so, all the way, yeah? And keep drawing, and keep looking. And it's around here, you may have noticed that, yeah, some people have said it, because I can see on the polls that 79% of people have said exactly right, that this is a buccal fracture. For those that can't see it, I'll draw it out. So first off, you draw around like so, draw around this area here. That looks very, very nice and smooth. But then when you come up to this area over here, you can feel there's a bit of an indentation there. Can you see that? Like so. So all we'll do, we just share the results for everyone to see that, yeah, most people got it, that there is something called a buccal fracture. Buccal because children's bones aren't like adult bones. Adult bones are very hard and they can crack, but children's bones, they bend and they bend and bend and then they break. So it's like a stalk appearance, like a stem of a plant. And you can see here, this is kind of really bent in like so. This is where the fracture is. And everything else, when you look at everything else looks very, very, very smooth all the way along like so. So therefore, that is a buccal fracture, just the way that we said it is. Okay, so good. Well done, everyone. We've done our first. We've got a few polls. I hope people find that useful. It had some really good feedback, and it's also quite a nice little thing to be able to have on the platform, and also make sure that people are keeping up with what's happening. Right, so let's have a look at this one. This person comes in with long-standing wrist pain. And let's just have a zoom in and let's pan around at first. So hopefully people can see something's quite strikingly abnormal. So, okay, let's follow the rules, okay? Let's follow the rules. First off, let's have a look at the fifth over here and the fourth, and they look very, very smooth, going along the line, along like this, along like so. That looks very, very smooth. The bases look very, very nice, I guess. But when you start zooming in a bit, you start to feel like there's actually maybe a little bit more going on around this area. So let's kind of pan and bring it across like so. So first off, is there any fracture? So let's have a look. No fracture from what I can see. Everything looks very nice, very, very nice all the way along. But then look, the growth, the joint space looks maintained all the way along. So there's no loss of joint space, right? So if we're thinking to ourselves, is there a fracture? We don't see that. Someone has thought maybe it's osteoarthritis, but with osteoarthritis, you've got to think, okay, what is the definition of osteoarthritis? And I remember someone saying it was like LOSS, right? So loss of joint space, osteophytosis, subarticular sclerosis, and subarticular cystic change, right? So do we have any of those things? So we don't have loss of joint space. We definitely don't. But we do have these areas of radiolucency. You can see there, a bit of radiolucency there, bit of radiolucency there, maybe a little bit of extra sclerosis. But generally speaking, the joint spaces are quite nicely maintained. Yeah. So when you've got that, when you've got like no loss of joint space, then you've got to think to yourself, when someone has got such bad looking wrists, essentially, what's going on? And it's actually not just the wrist. If we kind of pan along, oops, I've done the wrong thing. So let's go pan, bring that this way. And look, come up to that metacarpal head over there. And then if we go across to the next bit over, so yeah, the metacarpal head, and let's draw around that. And you can see that, first of all, that looks slightly like they're overlapping. So there's probably some level of subluxation. And you've got these like circular radiolucencies around here. So someone's mentioned, is it gout? Well, that's the thing. It kind of brings you down that particular road now, doesn't it? Osteoarthritis is just something that happens to all of us as we get older. We use our joints a lot and we end up getting osteoarthritis. But here, we've got no loss of joint space, multiple radiolucencies. Yeah, I get it. Some of them are in a sort of periarticular location. So you could say gout. But generally speaking, you're going to say this is to be keeping with some sort of inflammatory arthrosis rather than anything else. Now, gout usually is a single large joint that's got involved. I'm not saying it can't happen, but you've got to be thinking about other things as well. But yes, you could go down the idea of looking at urate levels or the blood levels to see whether there is underlying increased urate, which would therefore tell you this person has got gout. Now, Charcot joint has actually got its very own definition. 5Ds, from what I remember. You have to look up the exact 5Ds. But generally speaking, when you've got Charcot joint, you're talking about disruption, you got dislocation, you got debris, you got there's lots going on. There's complete loss of the normal joint appearance. But when you look at this, I don't think you could really say there's loss of joint appearance. You can still see the joint, you can still see the bones, you can see the way it is. But there's multiple areas of radiolucency. There's kind of areas where you've got increased radiolucency because it's basically an inflammatory process eating away at the bone around the joint, but not the joint space. The joint space is completely fine. There's no debris. So if there's lots of debris, then yeah, I'd say, look, there's some sort of underlying destruction, which could be Charcot joint. But I would shy away from that. Actually, the only thing you really say on this X-ray is that there's an underlying inflammatory process, and the inflammatory process is severe and is affecting the majority of the carpal bones and the metacarpal bones as well. So jury's out. It could be rheumatoid arthritis. It could be related to any sort of underlying connective tissue disease. But this can't be written off as osteoarthritis, mainly because of the maintenance of a joint space and the distribution as well. Oh, by the way, so distribution, generally speaking, with osteoarthritis, you'd have it around the areas where you use the most, right? So you'd have it in the regions of the radiocarpal joint, and you'd really have it in the distal interphalangeal joint. People are tapping away, doing sewing and whatever with the tips of the fingers. So that's going to be distribution. But here, there's kind of more metacarpal phalangeal joint. There's going to be the carpal joints as well. So those aren't areas that, you use, but don't use as much as that to end up with having significant arthritis looking like this. So when you've got such significant degenerative changes that are happening here, you've got to start thinking along the lines of, is this underlying inflammatory arthrosis? Right, so joint spaces, carpal region are all narrowed. You cannot say they are. Yeah, but okay, I get what you're saying. But when you look at the radiolucencies that are around there and the amount of changes that are there, like if it was such bad arthritis, there'd be such a significant loss of joint space. But because it seems as though the the radiolucence is so out proportion to the loss of joint space, I would still veer down the idea of this being an inflammatory arthrosis rather than osteoarthritis. Now, yes, you can get a combination of inflammatory arthrosis on a background of osteoarthritis, but I still think there's going to be an element of inflammatory arthrosis in this particular aspect. But I guess each to their own. You may feel differently. Okay, so we're going to go to this next case. This is the hip, okay, and we're just having a look at the hip. And generally speaking, what you do is just try and draw what I would try and do is draw the acetabulum and then also draw the neck and the head of the femur if possible. So here, we've only got one view, kind of on purpose, because otherwise it'd be a bit too easy, I think. So if we look at the neck of the femoral shaft going along like so, we can see we're coming up to what would probably be the lesser trochanter and the greater trochanter, somewhere around here. And you kind of come along this way, and you can't really 100% say that you can see the femoral head. Okay, so where is that femoral head? Lots of overlap, quite difficult to be 100% where the femoral head is. And then when you kind of look at the acetabulum, that's over here. Can you see that? And so if you start to really think about, okay, where would the femur be if the trajectory of the neck of the femur, where would the femoral head be if the trajectory of the femur is as so? So look, this is the femur like this, and you can see the neck of the femur goes this way. So generally speaking, you think that the femoral head should be somewhere over here. But in this area, you can't say that you can see the femoral head where the acetabulum is. So therefore, either you're looking at a dislocation or you're looking at a fracture of the neck of femur. And in this situation, you can actually start to look a bit closer and you can see there's a bit of a jagged edge there. So more than likely what's happened is there's not a dislocation. The femoral head is still involved, it's still there. But you do actually have a neck of femur fracture and that sort of a displacement of that fracture as well. So maybe that was a bit easy for some, but like I said, I do try and keep this open for everyone. But I think this is quite a nice basic thing to do. Always try and sort of draw along the trajectory of where the femur would be, then the femoral neck, and then where the femoral head, and then where does it place in regards to where you can see the acetabulum to 100% be. And then you're looking at, okay, is this a fracture or a dislocation? And this situation is clearly a fracture because you can see that sort of irregular cortex of that edge of the neck of femur. Okay, so we are just going to be opening this one. And I think there is a poll for this one as well. So hopefully that poll will come up. So when we're looking at this, we're looking at the shoulder. And ideally, yeah, you do want to have two views of the shoulder, don't you? But on this particular occasion, we haven't got two views. And we're just going to be looking at the AP view. And we can see that that actually does look like it's articulating quite nicely. We can see that, yeah, that's the humeral head. You can see the glenoid over here. And you can see that all kind of quite nicely lines up, can't you? It all looks kind of like it's lined up nicely. So I can't say at the moment there's any sort of dislocation, right? Now, the other thing I always do whenever we go up to these areas is just have a really, really close look at that sort of glenoid and just make sure there's no fracture here. Like sometimes you end up having a previous dislocation. Previous dislocation would be like this, and you get a bit of a knock-on effect in this area. So this area would hit this area because of the dislocation, and you can end up getting a fracture. So very, very important to have a really close look there. Make sure there's no fracture. Another place I've seen fractures being missed is the greater tuberosity. Now, sometimes what can happen, you can have a fall, you can have either direct impact onto that outer aspect, or you can have impaction of the lateral acromion with the greater tuberosity and end up getting with a little fleck of a fracture, a big fracture, a bit of increased cortication within that region. But I don't think we can say that there is a fracture located within this area at all. So you could walk away thinking, well, you know what, I think this is actually pretty normal. But actually, when you look at that clavicle, there's something not quite right about this clavicle. And what we'll do, we just draw along like we always do. So that's the underside of the acromion, which is over here. And then you've got your clavicle that's over here. Can you see that? And there's complete massive distance between the two. And so therefore there is something up with this, right? This is incorrectly placed, them out of line. Now, I get it. Like, you know, when you've got one view and you don't have a dedicated view of the clavicle, then you can say, look, I'm not 100% right. Because, you know, even if you look at something like this and the complete line, but depending on the angle that the person is in, they can start to look out of line, even though I haven't actually moved my hands aligned from one another. Just the angle of the way the x-ray is taken can be a bit off. But when it's this much, when it's this far above, you really, really have to raise it. Now, oh yeah, we've got a poll, and what have we said? So yeah, good. So people we've talked about, the reason I put this poll up is to try and see what people think or know, whether people know the ligaments that exist when it comes to what's holding that clavicle in place, right? So first off, you do have something called the acromioclavicular ligament, which is over here, right? Then you've got another two ligaments that go like this and like this, right? So the furthest one is, I guess you could say, looks like a trapezium. So that's a trapezoid, yeah. And then you've got your conoid, which is over here. And so those things hold everything in place. But here, you feel like there's going to be a definite disruption of the acromioclavicular, and there may be a disruption of one of these two as well. And that's why it's quite good to try and have a look underneath, try and see where there's an avulsion fracture, see where there's an avulsion fracture over here as well. So people have they caught it out? So we said, yeah, so some people said trapezium. So that was a bit of a trick. Trapezium is anatomical wrist bone. Got nothing to do with the shoulder. The rest of those ligaments are true ligaments. The trapezoid ligament and the conoid ligament are actual ligaments that exist within the shoulder. So I kind of tricked you guys and some of you fell for it. Sorry. Okay, so let's close that poll and no questions so far. And what I'm going to do is go to the next case. So let's have a look at this case. Hopefully it's straightforward. I hope it is anyway. So let's have a look at this. This is a chest x-ray once it loads up. Okay, what I might do, shouldn't take this long. So maybe the kids are watching Netflix downstairs. So we're going to be looking at chest x-ray. And I mean, chest x-rays can get really, really complicated because there's just so much anatomy on a 2D image, right? So what you have to realize when you're looking at any sort of part of the body, especially when it comes to the chest, when it comes to the abdomen, you're looking at a 2D representation of a 3D structure. So therefore things can hide behind other structures, things can hide in front of other structures, underneath other structures. And there's a lot of structures, like it looks like it should be very straightforward, but it's actually not. There's just so many bits of anatomy to be aware of. For those that don't know, this is going to be the aortic arch. You've got your trachea that's going right down the center, and it kind of splits into the bronchi, the main bronchi over there. And you've got your heart that's sitting over here. Okay, so that's good. And then you've got your hilar. So these are your hilar regions over here. And this hilar in this area looks slightly more dense when you look at the other side. What I'll do, I'll zoom in just to show you. So let's zoom in a bit. Oops, zoom. And then pan that across. So when we look at this hilum, it doesn't look so dense, right? But when you look at this hilum over here, this looks a little bit more like increase in density. So you're probably thinking there's probably some sort of hilar lymphadenopathy. So for those that don't know, lymph nodes can get large when someone's got infection as part of the lymphatic system. When you've got infection, they can get enlarged. And you can have perihilar, perimediastinal lymph nodes. There's loads of these lymph nodes hiding all over the place. But in this particular x-ray, you feel like, actually, you know what, I think there is a bit of hilar lymphadenopathy located within this region over here. And then when we kind of come out, yeah, some people have said it. Hopefully it is fairly straightforward, but you can see there's clearly some sort of abnormality that is going on within this region over here. Now, generally speaking, people are going to try and be smart and say which lobe it is. I try and stay away from lobes, especially when it comes to x-rays, unless it's blindingly obvious. But otherwise, I would just say, look, there is a right mid-zone opacification. Now, what is the opacification? Is it a pleural effusion? Is it a mass? Or is it consolidation? Now, the thing is with consolidation, what you're really looking for is a telltale sign known as air bronchograms. So what you're looking for are these areas of radiolucency, which are very, very linear, right? A little bit like those vascular channels that we were talking about earlier. And then there's all this gunk around it, right? And that's because it's like a straw within a bottle. And when you fill up the bottle with fluid, the straw doesn't get full, but the rest of the bottle gets full. And that's exactly what happens. You've got a nice little straw that's sitting here, a whole lot of gunk and fluid sitting around it, but the straw is maintained. The airway of the straw is maintained. So when you kind of look in, yeah, you can see the sort of linear radiolucencies going all the way through it in the midst of this extensive opacification. Therefore, this would be in keeping with consolidation. And remember, consolidation can happen for lots of reasons. Tumors can cause consolidation. It could be infection, it can be blood, it could be lymph, all sorts of things. So generally speaking, you just have to say, there's shadowing of the right middle zone with evidence of air bronchograms, which could be in keeping with infection or inflammation, depending on the clinical picture. And sometimes what we end up doing is doing a follow-up. Exactly, yeah. So someone said blood, pus, water, and cells. And so it could be tumor as well. And so what you end up doing is doing a follow-up. And obviously, if it doesn't disappear or get worse after, let's say, you treat it with antibiotics, you probably want to take things a little bit further, especially if you've got lymph nodes sitting there, and that maybe you've got more lymph nodes later on. It is worth taking it further because obviously malignancies can end up looking like consolidation, like an infected consolidation when it isn't. So let's start with the X-ray first. Let's have a look and see what's going on. So the check areas I have whenever I'm looking at any sort of foot x-ray is to first off have a look at the shafts of the bone, just to make sure there's no fuzziness. And when you have fuzziness, that means that there is a stress fracture. Here, there's no stress fracture from what we could tell. The next thing you want to do is make sure you have a look at the metatarsal heads, because sometimes you get a vascular-necrosis. It looks very, very sclerotic, known as Freiberg's or Freiberg's infraction, depending on where you're from. And then the last thing I always do is try and make sure I've had a good look at the actual terminal phalanges, right? So because sometimes people have stubbed their toe, they've hit their toe, someone stepped on them. So you've got to really make sure that there's no fracture along these tufts, right? And the thing I've said before, for those who come to these talks before, is have a really good look at that nail and make sure that nail goes all the way across. Because if you've got another line that's apart from that nail, either they've got some sort of, when people get little like decorations on their foot, which I have been caught out by the way, they've got decorations of the foot which make it look like a fracture, or they've actually got a fracture. And then the other thing to do is have a look at that soft tissue. So if it looks like soft tissue like this, and suddenly gets really, really large like this, then you're worried that, okay, there's soft tissue reaction, inflammation, there could be some sort of injury there. But here we don't have any injuries as far as we can tell. So then what we're going to do is really go down the long road, right? We're going to have to really start drawing around each of the bones. Now, another check area I really want to make sure people are aware of is the navicular. When you zoom into this navicular, you do worry there could be something going on there, right? So look, let's zoom in. So there's a couple of things it could be. Either it could be an os, so you can get an os navicular, but you also worried that there is this radiolucency that seems to be going along like so. So we need to be paying attention to this as well, especially in the context of trauma. But the one thing that people have said, which is very good, is that there is what looks like a fracture of the base, right? The base of the second metatarsal. Can you see that? Then you've got a line like this. You've got a line like this, right? And there may be a possible another one over there, but there's definitely a fracture here. So one of the reasons you'd be worried about here is that you actually got a ligament that sits between this medial cuneiform and the base of the second metatarsal, and that kind of holds everything in place, and that's called the Lisfranc ligament, right? And if that tears, what can happen is that you get like a dislocation, or basically a migration of all the metatarsals right across. So that doesn't get picked up. They can end up having a more significant injury later on, or basically development of more of a significant injury. Now, this is clearly something to worry about, and then we'd also worry about the rest of the bases of the metatarsals as well. But actually, everything else looks okay, and the only thing that's going to be a little bit worried is that navicular. And actually, we do have the CT scan. So let's zoom into the CT and see what we can see, as it were. So let's download. What happens sometimes, if it does get a bit slow, what I recommend is clicking on that little cloud button. So those that didn't see it, there's a cloud button that's sitting over here. Use that downloads the images quite nicely, and then you get like a really nice smooth smooth scroll through the images. So unfortunately, it looks like this patient might have moved a bit. We just have to wait for that to go all the way across, and then we should be able to go through. So let's zoom in a little bit more. Zoom in. Let's scroll through. So first off, let's find. Okay, so the navicular doesn't look too bad from what I can tell, is it? No, it's moved a bit, but I think the navicular is actually okay. So, okay, but then what we can see is a fracture there. Can you see that? So if we do that, get my pen out, there is a fracture that's sitting over here. And then that's when you've got to be worried that is there any other fractures. Unfortunately, the patient's moved a bit when they were in the scanner. So it's going to be a little bit difficult to be 100%. There's not a smaller fracture somewhere here or somewhere here, which is a real shame. But I think, what's ended up happening is that they were clearly worried that there could be more fractures than the ones that we saw. End up getting the CT scan to find out whether there's a ligamentous injury. Now, what you can do is try and go to soft tissue windows sometimes. And if you're lucky, you can actually see the ligament quite nicely, the Lisfranc ligament I was talking about earlier. And I could almost convince myself there is a linear line just there, which is probably an attached Lisfranc ligament. But again, I guess if you're remotely worried, just get an MRI scan to be 100% on that, yeah? But anyway, that's quite a good X-ray with a nice little follow-up of a CT scan as well. Right, so let's have a look at this X-ray. Let's go for the X-rays first. A few things are popping up. I'm just going to click on download for a second while that comes up. And then what we'll do, we'll go to the knee. So this person is a 35-year-old. They were playing football and they ended up having a bit of a knee injury and getting quite hurt. They couldn't move their knee and they came in getting this X-ray. So first off, we've got to really have a look around. So common places to have fractures are going to be What would be so I would actually look at the tibial spines. Though that's a really important place to look, and the fibula head as well. So let's zoom in first. And can you see that fibula head doesn't look quite right to me? I'm a bit worried there could be something else going on there. It looks a little bit like overlappy, if that makes any sense. I probably made that word up, haven't I? But when you really go into this area here and you start drawing along the lateral and medial tibial plateaus, you can see, look, that's the medial tibial plateau like this, radiolucency, radiolucency, and then you kind of draw along like this. It feels like there could be a radiolucency there going along like this. Maybe that is a bit of an overlap rather than being an actual fracture. There's a few things that got me worried. This one, but definitely this one. So let's have a look and see what it looks like on another view. Maybe that will give us a bit more of a clue. Let's zoom in and zoom in and zoom in and have a look. So this can be a bit difficult, isn't it? So I do wonder whether you can actually see that there is a bit of a radiolucency just sitting within this region here, maybe a bit of flex a bone. But if you've got a big fracture, then you'd probably be worried that there's some lipohemarthrosis. Lipohemarthrosis, we get blood and pus sitting in the suprapatellar region of the knee. But I don't think you can really say that 100% on this X-ray at the time of the study. Maybe angulated incorrectly for this particular X-ray. But I can't 100% say that I can say that there is lipohemarthrosis. So now let's have a look at the, so one of my consultants say, let's have a look at the truth data. So the truth data by definition, I guess, would be the CT scan. And you can see here, these radiolucencies on the actual views anyway. Let's have a look. Radiolucency here, radiolucency here, radiolucency here, all sitting within the region of the tibial spines. And then there's a fracture of that posterior aspect of the lateral tibial plateau. Can you see that over there? So there's quite a significant fracture. And actually what you can do here, which is really cool, you can do MPR and go Corolla on it. And it's just like having your own packs at home. Well, I don't know if anyone's got packs at home, but wherever you work, you can literally do the MPR and have a good look around and see whether there's any fracture. Now, like someone else, I thought maybe there could be a fibular fracture, but looking through here, I don't think we can say there's a fibular fracture at all. The fibula looks okay, but we have confirmed there's a significant fracture of what looks like the tibial spines that extends through to the lateral tibial plateau, and we can see that extends posteriorly. Now, what else is there to worry about with these X-rays or the CT scans, especially when you get fractures here, is an ACL injury. An ACL injury is going to be of a high possibility in someone like this, because what can happen is that the injury could be, so usually in an adult, you'd get a tear of the ACL, but in these situations, and younger patients in particular, you can end up getting an avulsion. So the ACL, the anterior cruciate ligament, can pull really hard on where it inserts into the anterior tibial spine, anterior aspect of the tibial spines, and then end up getting an avulsion fracture. Now, I don't think you can be 100% on this. Let's see if we can go MPR and go sagittal. And then if we go to these views, you can see the PCL. I don't know if people can see that. PCL is sitting here. And now if we scroll through, can we identify an ACL? Can't be 100%. Maybe you could say it's just here. You see that? A bit of a line there. So a bit of a push, fair enough. It may be a bit of a push, but you do worry there could be a bit of an avulsion here. So they're going to end up needing to get an MRI scan as well. And then I guess, someone's saying that, there could be a secondary fracture further down, right? Yeah, you may want to do a fracture, an X-ray or some imaging further down to see whether there's a concurrent fracture of the fibula as well. Right, so let's have a look at the next case. Okay, so this is a bit similar to the other case that we had, but I still think it's a good learning point. Okay, so, actually, it is quite related to the other one that we had. Okay, let's have a look at this one. So first off, this is an X-ray of someone's foot, and we feel as though there's a bit of soft tissue swelling. You see that all looks very, very like full around that area. So it doesn't look quite right to me. Let's have a look at the rest of the joints. So lots of fullness around there. Let's go to the rest of the joints. These joint spaces are nicely preserved, so that's good. And we keep coming up to this area, and these metatarsal heads are a bit difficult to fully delineate. So let's zoom in. But that, sometimes the metatarsal heads can be just generally difficult to see. But when you look at the base of the second proximal phalanx, it looks very, very irregular. And there's all this kind of soft tissue / hyperdensity sitting here. And then this looks like the joint space is nicely well preserved, but these kind of hyperdensities sitting within these regions over here as well. So that doesn't look quite right. And then what we'll do, we can actually see, this area looks quite swollen as well. There's a bit of soft tissue swelling located within this region over here as well. So it looks like it's mainly based over the first metatarsal as well. Let's have a look at the rest of the bone. So let's go and have a look at these joints and see if we can find anything else grossly abnormal. These don't look quite right either. They just look a little bit osteopenic, I guess is the word, around the corners over here. Doesn't look quite right. You may be worried there could be a bit of fracture there. I wouldn't go down a fracture road here. They didn't come in with trauma anyway. And then let's have a look at the large joints as well. So zoom. Let's do reset. Might be easier to do reset. Reset all. Okay, let's have a look. So everything else looks okay, but you know what keeps catching my eye is that area there. So actually what you have are areas of what looks like radiolucencies, and you've got areas of the areas that have got radiolucencies also got associated higher density material and soft tissue swelling, right? And the erosions or radiolucencies are kind of not in the joint space, as it were. They're kind of outside the joint space, or otherwise known as periarticular erosive changes. So therefore, this would be most likely to be in keeping with gout. So gout is going to have increased urate levels that normally affect the large joints, so the ankle joints, the first metatarsophalangeal joint, very, very common places to end up having gout. And that's what we can see here. We can actually see, yeah, there is a sort of soft tissue density association with some, erosive changes located within the first metatarsal. And you know what, I reckon if we zoom into the ankle, you start to really feel as, okay, there's not just it's not just there's some radiolucency, but maybe a little bit more radiolucency around that that talar dome as well, possibly. So we probably need to have a dedicated view. Someone says hello back to you as well. Welcome. If you've just arrived, don't worry, you can watch the recording later. It's on YouTube. Right. So let's have a look at the next case. And this is the reason I brought this. Okay, so there's a poll with this one as well. So I'm going to download this. Hopefully the poll will come up. And then we'll go through pathology, and then people can try and answer the question as well. Yeah, someone has said that might be a tophaceous gout. Yeah, exactly. So tophaceous gout or gouty tophi, as it were. Yeah, it could be those things. Exactly right. Well done. Right. So let's have a look at this CT scan. So this scan was a CT pelvis, and someone came in post-trauma. And then when you're going through this, let's zoom in a bit because my screen is a little bit small. And then let's pan. And then go through here. Hang on, so let's go through. Going through. So, when you come to this area here, this bone, if we kind of draw, okay, if you look at the bone over here, can you see how kind of very, very linear, well-organized, it is, you can see it looks quite nice. But when you look here, it looks a little bit sort of irregular, a bit mottled, maybe a few kind of radiolucencies dotted around, slightly expanded. Look, that compared to that looks a bit bigger, doesn't it? Yes, okay, I get it. It could be slightly angulated differently, but it doesn't look quite normal. It looks a little bit expanded. It doesn't look quite happy. Coming further down. Yeah, again, you can see, look at that kind of area there. Very nicely, well corticated, no expansion, loss of cortication, expansion, radiolucency, and then what looks like a fracture there, okay? Over here, you can again see some sort of what looks like maybe a lytic area. This area looks kind of slightly expanded as well, kind of loss of normal trabeculation. So trabeculation is kind of this area between the kind of harder cortication. This looks very, very kind of expanded and loss of trabeculation. So these are all worrying signs, right? We're worried that there's something more going on than what meets the eye. So what we can see here is that there is probably some sort of underlying disease process, such as a malignancy that's going on, causing in multiple areas of destructive process. And what this anatomical area over here is actually the lesser trochanter. So why is that important? Because the lesser trochanter is very, very difficult to get fractures in, very, very difficult to get avulsion injuries in, right? And what attaches to this, let's see what people have said, exactly right. Your iliopsoas tendon goes all the way around like this and attaches there. So if you're going to have anything avulse, it would be the iliopsoas muscle that would pull away. Difficult thing to happen at all. And so what's ended up happening is that you do have a fracture. So when you have a fracture of the lesser trochanter, you've got to have like alarm bells ringing, like there's something else going on. Either got weakened bone, which is what we see, got what looks like an underlying destructive process, or they've got some sort of pelvic malignancy, like some sort of pelvic mass that is resulting in sort of the lack of ability for the tendon to kind of shift along and move the way it normally would. And therefore, if you've got a lesser tuberosity a lesser tuberosity fracture, you should really start thinking about other things that could be beyond just, oh, is this just trauma? There's something else going on. And in this particular patient, clearly there's a lot more going on, because as you can see, there's a destructive process located within the region of the left trochanter, the inferior pubic ramus on both sides from the looks of things. Let's see if we can find any others. Yeah, look, that acetabulum doesn't look quite right either. Look, there's just lots of expansile bony, destructive bone lesions around, meaning this person's got an underlying malignancy. Now, just if this is the only thing I had, like a pro tip, I guess, would be don't give up just because you've seen the fracture. Is, try and have a look and see what else could be causing the problem, right? So have a look at the bowel, make sure there's no concurrent malignancy, because sometimes you do pick that up. Sometimes there's a liver, a bladder malignancy that you might be able to pick up as well. And yeah, they've got a urinary bladder catheter as well. So that's something to think about. So while they've got a catheter, they've got a larger prostate, maybe they've got underlying prostate cancer. It's a possibility. Generally speaking, with prostate cancer, you'd get sclerotic lesions, which I guess this is. So something to consider. And that may be the clue as to why this patient's got this underlying problem, which has resulted in their fracture of that lesser trochanter. So everyone's done that well, actually. So everyone knows anatomy quite well. This is very, very good. Right. So let's go to the next case. I'm going to close that and go to the next case. So this came on from the wild, as it were, during a busy on-call, and quite a young patient turns up feeling very, very unwell and peripherally shut down. So that means that they're coming across like they've got, I'm glad I'm not the only one who says that. Big muscles, yeah. Because sometimes I'm looking at scans and I'm like, whoa, this guy's big. And I thought maybe that's because I'm obsessed with going to the gym these days. But and by the way, I am on Radiopedia this year. So if you are coming, I'm doing a talk on gym injuries and bodybuilding. So it'd be very interesting if you, it'd be great if you'd support me and come along to Radiopedia this year. Anyway, a little plug since that came up. Okay, let's have a look. So yeah, you're right. I mean, they're clearly no strange to deadlifts. They do have quite big psoas muscles, okay? So when we have a look at the psoas muscles, these are the psoas muscles here. And yeah, they've got a bit of subcutaneous fat, but their muscles are fairly big. So someone who's quite young, actually, right? And then as we kind of scroll through, you see that spleen looks okay there. I can't see a laceration, but there's sort of extra material sitting around the outside of that spleen. Can you see that? That doesn't look quite right. Coming down, yeah, that just looks like there's higher density over here. So then what you do, you kind of scroll down and look, and actually there's increased density located here, some fluid, but it's not normal fluid. Like a pro tip for you guys is what you do, you get the Hauser unit, measure the density there, and then you go to the gallbladder, measure the density there. And if it's higher than the gallbladder, then you should be worried that there is a bleed. If the gallbladder doesn't work, then use a urinary bladder, do a measurement there, and then compare it. But just using your eyes, look at that urinary bladder, and then come back up to that higher density fluid sitting up here. You can see that's very much higher density than the urinary bladder fluid. So this looks like quite a significant hematoma, right? So now you think, okay, what's going on? You've got a young patient who's got what looks like a large hematoma. Where did it come from? Now, when you look at the hematoma that's over in this region and you compare it to the hematoma that's here, it feels like the hematoma is slightly more dense within this region here. So you'd probably be a safe bet to say that the most likely source of this bleed is going to be a splenic injury. Most likely, right? But here, I don't think you can 100% say that you can see an active point of bleeding, but we only got one phase, and we can't see a laceration, and there was no history of trauma as far as we can see. So the other thing to do, a pro tip for you guys, is to go to the bone windows and also have a look and just make sure there's no broken ribs. And I've had this situation where you've got, you can't see anything, and then there's like a little tiny fracture of one of these lower ribs. This wasn't the case on this situation. It almost seems like a spontaneous. And yes, you're right. Blunt injuries can cause it, playing football, getting hit. In fact, we had one turn up, and there was a very young man, and he was canoeing. So for those that don't know, canoeing is like this little boat, but you're really kind of shoved inside this canoe. And they had a great weekend, but then started feeling really sick later in the day. They got back and started feeling worse and worse, and ended up having a splenectomy because actually in the canoeing, I think they must have gone down some river rapids or whatever it was, ended up getting quite a significant injury. So let's have a look at the coronals. Yes, someone's asking, and these are exactly the right questions that we should be asking. So yeah, someone said, look, let's have the coronals because yeah, if someone has got a big spleen, then you'd be worried that they are more likely to have a bleed. But I mean, I don't have measurements here from what I can. Oh, do we have measurements? Yeah, so line, let's see. I don't remember the spleen being that big. I mean, 12. Yeah, I mean, it's not huge, is it? And actually the morphology of the spleen is actually not too bad because it looks very, very thin. Normally when you get splenomegaly, it'd be like, really, really globular. So jury's out on why it happened, but they definitely have a significant bleed. So I think more than likely, if we're worried that they're continuing to bleed, there's a couple more things I want to talk about actually. Let's bring that back. Sorry. So when you're worried about why they're bleeding and that kind of thing, you may end up doing a triple phase scan. So you do a pre-contrast where there's no contrast, an arterial phase, and you want to do a portovenous phase to see whether the person has got an active bleeding point, whether this contrast comes out. And also, when someone is young and they're bled, you also want to make sure what does the IVC look like, right? So the IVC is this structure over here. That's the aorta over here. And you want to make sure that's spherical all the way around, because if it becomes flattened like a pancake, known as pancake IVC for those that are hungry, then you're looking at hypovolemia because they bled so much that they don't have enough blood volume. So you want to make sure that this is still circular, and you want to make sure they've got no secondary ischemia or anything like that. Now, interestingly, you can actually still have a hypovolemic syndrome. And hypovolemic syndrome is basically where you've got lack of blood flow, increased lack of blood flow to the vital organs. So you end up having, I think, increased blood flow to the bowel, I think small bowel, the adrenals. I think that's it. And you can actually have a normal looking IVC, but signs of hypovolemia, because what's ended up happening is that whilst trying to fluid resuscitate the patient with just fluids, they managed to resuscitate that compartment, but they're still not getting enough like red blood cells around, so they end up still getting this sort of semi-hypoxic situation going on. So that I've seen that happen. So it's just something to be worried about. Things like hypovolemia syndrome or something like that is quite interesting. Right, so let's have so these are some of the donated cases. So no questions. Yeah, CMV. Yeah, okay, yeah. Oh wait, someone's asking about possible reasons as to why the person could have had this situation. Yeah, I mean, it could be lymphoma, bloodborne diseases that can result in increased spleen size. But on this particular situation, I don't think we really found out why they got such a big spleen. Sorry, why they had this splenic injury. So here we have a question. It says the TTTG. Okay, so someone did actually ask, what would you measure, right? So what we'll do, we'll just put that to the side. People are going to start putting their answers in. So let's have a look at this MRI scan. So what we have here are, so this looks like a single image. So this looks like multiple images here. So let's have a look through. So these are the axial images. And as we scroll through, we can see fluid is bright. So these are the fluid sensitive sequences. For those that don't know, fluid is sitting over here and here. And we can see fluid is bright. And actually the bone marrow, which is going to be mainly fat, is very, very darkened. So this is a fat saturated image as well. And as you scroll through, you can start to see that this looks very, very different to this area over here. So you think, okay, so there's increased fluid located within the region of the femoral condyle. Which femoral condyle is it? Well, it's actually the lateral femoral condyle. Fibula is there coming up. Yeah, lateral femoral condyle. So now you want to make sure that, what does that look like? Does it look flat? Does it look like indented or anything like that? It doesn't look indented, but there's definitely a very focal bone marrow edema located within this region. So that's going to be a pattern of injury that can happen. And what can happen is that you can get the patella. Let's go to patella, which is sitting over here. That can go laterally displaced and end up trying to get back into where it belongs, hitting the side and then scraping along like so and ending up over there. So a couple of things can happen. First off, or three things, you can get a bone marrow edema over here, which is what we see. You're going to have bone marrow edema on the medial aspect of the patella, which actually you can see. So that's ended up clearly hitting that area over there. And then you can also get fractures as well and tears of ligaments, right? So you want to make sure there's no fracture. So the cortex is going here, maybe a loss of cortex over there. So you could be looking at an impaction fracture. You've got your medial patellofemoral ligament that goes along like so. Is this torn? Well, the mid substance isn't. The proximal substance isn't. And actually the more distal substance is not torn as well. Coming up here, there's probably a bit of increased signal located within the area. So it's probably a very high grade sprain of that area. Now the person has asked us, what would we measure? So what would we measure is going to be something called the TTTG. And that's, I'll show you how to measure it for those that don't know. It's basically like a measurement of the propensity of someone or the likeliness of someone who's going to end up, oh, what's going on? Oh, polls come through. Okay, that's why my screen suddenly disappeared. It's the propensity of someone to be prone to have a dislocation again, because if someone has got anatomical variations that results in the ability to basically dislocate the shoulder, dislocate the patella, we can actually make measurements. So first of all, one of the things we're going to be looking at is the how flat is that trochlear groove. So if it's a nice V shape, then we're not too worried. It looks okay. And I guess it's a nice V shape. But then when you come up to this area here, so let's get the measurement tool. And then you go from here. And I literally put the mouse over here, scroll up, scroll up, scroll up, get to that trochlear groove, and then draw, line. Let's try again. From here, from here, from here. And then you draw a line like so, like this, yeah? And so then that gives you a measurement, 1.5, right? So they say that anything less than like 1.5 is kind of normal. Anything between 15 millimeters and 20 millimeters is going to be like borderline. Anything above like 20 is going to be very significant increased TTG. So the fact that this person is borderline, or actually quite big on that area, is how do we delete that? Delete, erase. It's quite large. And they've also had this situation of this increased bone marrow signal located within the medial aspect of the patella and the lateral femoral condyle. Then, yeah, you're worried that this person's going to have a propensity to having patellar dislocations. And so they may need to be discussed with the orthopods, and they may need to sort of shift this across so they're less likely to have future dislocations. So let's go to, so we're doing okay for time. Okay, we're doing good for time. So let's do this one. So another donated case, thank you very much. Always appreciate it. And by the way, what we're going to try and do is see if people actually want to take part in the webinar, i.e. present their own cases, talk through cases. If they've got learning points they want to impart onto me, because I don't know everything and other people may want to learn too, then, feel free, let us know, drop an email, drop a message, and we'll be able to sort that out. So again, let's have a look at this axial view. And again, we're looking at this patella, and coming up to this area here, can you see, we don't have that sort of increased bone marrow signal there. We don't have increased bone marrow signal there. So we're not looking at dislocation. That the ligaments actually look okay as well. But when you come up to this area here, can you see this sort of increased fluid signal located within that area? So where are we looking at? We're looking at the lateral aspect of that patella. So let's go to these sagittal views. And so sometimes you can get a little bit of edema in the superlateral aspect of Hoffer's fat pad, and that is called Hoffer's fat pad impingement. Interestingly, I've seen that you can get some edema located within this area over here. There's known as quadriceps impingement as well. And this area, yeah, you definitely got some increased edema that's very, very out of proportion to anywhere else. Therefore, meaning this person's got some sort of impingement. But more importantly, as you go through, you can see that patella tendon going like so. And then it looks like it's a bit irregular around there. But then, unlike a clean sort of break, right, this looks a bit irregular, a little bit of edema. Around this area over here, you've got sort of increased cortication. This is a chronic process that's been going on. This is a chronic thing that's been going on. This is not something that's just happened out of the blue. So more than likely, this unfortunate patient's been complaining and having pain for quite a while. But you can see here on the sort of axial views, it does look like there's a bit of a bite out of here. So this could be a combination of reasons. They look like they're fairly young. You can't see much in the way of osteoarthritis, and the rest of the chondral surfaces look all right, actually. So they may be fairly active. But in these situations, you can either have like an old injury. Sometimes you have calcium deposition located within this region as a result of repeated injury. In fact, someone that I now work out with, he's actually got some calcium located in the region of his distal patella as a result of doing squats for so many years. And I think at some point, he ended up getting an injury. He said it hurt at one point, and he just left it, with a very, very hard area of calcium. And like calcific tendinosis, quite rare, but can happen in other parts of the body apart from the shoulder. But this looks like what looks like a bit of a chronic tendinosis and a bit of a chronic tear that is located here. It's a quite interesting case, probably quite an active person. And let's say you didn't have any of this, none of this, and you just had the edema, then at least you'd walk away saying this person's got Hoffer's fat pad impingement, which is something that can cause pain. Okay, so as usual, so someone says thank you. You're welcome. It's always my pleasure more than yours. I do enjoy this. I do enjoy people turning up and giving me their time. I value your time so much. I really appreciate when people give me their time. Do keep tagging me. Do follow me on social media. Do check out Collective Minds if you're not already using it. I use it for all my teaching, all my courses that we run it all through Collective Minds. They're a phenomenal crew. I have got to know them personally, and they're really, really great. And the actual community is very, very good as well, where you can actually get involved, look at interesting cases for yourselves as well. So do get involved. And familiar few names. I always appreciate your company. All right. So for me, thank you, everyone. I'm going to stop sharing and hand it across to my wonderful cousin, Seidel. All right, bye.
Thank you, Imran. Well done as always. And very nice to see so many new and familiar faces in the chat. As always, take some time to fill out the feedback evaluation form. So we can, edit based on your feedback. Once you have submitted the feedback form, we will also send out the CPD certificates for you. And remember that you can go through all the different webinars that were done previously. They're all uploaded in to YouTube. And if you go to our landing page, all the cases that we're going through, I think it's around 120, 130 different cases, similar to the one you just watched on this webinar. So if you have missed the webinar, don't worry, you can easily go back and watch it. And with that being said, I hope that all of you have a continued good rest of your day. It's really good weather here in Sweden finally, so I'm very, very happy. So yeah, so I will see you on the next webinar. Right, bye bye.